Good morning. I am Dr. Hira Nadeem, Infectious Diseases Fellow at Indus Hospital Karachi. The title of my CPC today is Muddy Waters, Murky Truths. Beginning with a case history. A 30-year-old man, resident of Karachi, single, living with parents, tailor master by profession, given up on cocaine, church, and smoking a year ago, came to the TB clinic on December 8, 2024, with a history of fever and weight loss for 4 months, behaving with aggression and confusion for 2 weeks. The fever was documented, Tmax 101 Fahrenheit with night sweats and evening rides. Weight loss was subjective, but significant enough to cause loosening of clothes.
Dr. Hira, sorry for the interruption. Your slides are not changing. It's showing the same slide one. It's also not in the slideshow.
Also, there's an echo in your voice. Please try and improve on that.
Can you see the slides now?
Are the slides moving now?
I can see history of presenting illness slide, but it's not in the slideshow mode.
Okay, our slides are moving in the slideshow mode.
Now it's in the slideshow mode.
सबको कह रहे हैं इनको आ रहा है ठीक है all right. Can you see the examination slide now?
Yes.
Okay.
Can you see the examination slide now?
Yes, we can see Dr. Hira.
Widely stable, looking distressed, oriented in time, place, and person, with no cervical, axillary, or inguinal lymphadenopathy. The neck was stiff. The Kernick sign was positive. Power was 5/5 in all 4 limbs, with intact sensory and cerebellar functions. There was no cranial nerve deficit. The auscultation of chest revealed normal vesicular breathing. There were no added heart sounds, and the abdomen was soft and non-tender to palpation. Coming to investigations, the blood was run for routine labs and found normal. A chest x-ray was taken, and that's how it looks. Can anyone comment on its findings?
Fellows, anyone could comment on this chest X-rays findings? Maybe from Shaukat Khanum?
Okay, so we can find some comments in the chat box. So that's very true. There are numerous small, uniformly sized nodules, 1 to 3 mm, scattered throughout the both lung fields, resembling millet seeds, giving the impression of miliary TB. Considering the neck stiffness and miliary lungs, an MRI brain with contrast was advised, and that's how it looks. Can you appreciate anything over here? So that's true. There are multiple ring-enhancing lesions seen in both supra and infratentorial areas, with diffuse meningeal enhancement seen most marked in the basilar area. For biochemical evidence of meningitis, an LP was done. The CSF was seen very turbid and deep yellow. The proteins were found exceptionally high, amounting about 3 grams, indicating
Dr. Hira, we can't hear you.
I think there are some connectivity issues in the area, so maybe they're logging in again.
हेलो डॉक्टर
Assalamualaikum.
आमिर
Gee, we're having some audio issue here, so we're just changing the laptop.
डॉक्टर आमिर आपकी आवाज नहीं आ रही इंडस वी कांट हियर यू
Gee, Lufthansa, we're working on it.
हेलो
जी,
जी जी आप आ रही
Lufthansa,
है जी आपकी
आ
आवाज
रही
आ
है?
गई जी जी
Okay, okay. Give us 1 second. Go ahead.
Recording in progress.
Lufthansa, please make me the co-host. आमिर काजी के नाम से. Lufthansa,
जी जी
please allow me to share my screen.
जी योर को होस्ट एंड नाउ यू कैन शेयर योर स्क्रीन
वहां से मैं मल्टीपल शेयर कर रहा हूँ ये इनको को हटा दें इनको डॉक्टर हिरा को
उससे कोई फर्क नहीं पड़ता लेट हिम बी को होस्ट एज वेल
जी रुकमान साहब हमें एरर आ रहा है कि the host isn't allowing sharing for this meeting. आप मल्टी शेयर ऑप्शन अलाउ कर दें.
उसमें फिर बहुत सारे लोग जो है ना वो सब अपनी स्क्रीन शेयर कर सकेंगे फिर मुश्किल ना हो जाए आप देख लीजिए अगर आप कहते हैं तो मैं कर देता हूँ
अलाउ कर दें.
तो आप मुझे दोबारा रिक्वेस्ट भेज दें मल्टी शेयरिंग के लिए जो आपने अभी भेजी थी डॉक्टर आमिर
जी
आपने अभी मल्टी
हमारे
शेयरिंग के लिए मुझे रिक्वेस्ट की थी ना वो
मल्टी
दोबारा
शेयरिंग का वो नहीं भेज सकते आपको. आपने वहां से ना ऑप्शन में जाके अलाउ करना होगा. हम मल्टी शेयरिंग रिक्वेस्ट नहीं कर सकते.
अभी आपकी आई थी तो मैंने उसे डिक्लाइन कर दिया था
वो एक ही दफा अलाउ कर रहा है. भेजना वो रिक्वेस्ट दोबारा नहीं मिल रहा. हमें होस्ट के राइट्स दे दें फुल.
अच्छा मैं आपको होस्ट के फुल राइट्स दे देता हूँ Now your host.
Is it audible now? Considering the chest X-ray findings, the tuberculosis in the MRI brain, in the high proteins in the CSF, what is the diagnosis? Any hints at the diagnosis?
Right,
Let me just give a short snap of where we left. So the patient with a history of fever, weight loss of 4 months came up. On examination, the neck was stiff. There was no other significant finding. The chest X-ray showed miliary lungs. The MRI brain showed tuberculoma with meningeal enhancements. The CFS analysis showed very high proteins reaching about 3.5 grams. So where do we stand? What is the diagnosis? That's true. Being clinico-radiologically relevant, despite gene expert turning up negative, a diagnosis of miliary TB with TBM was made and treatment was started.
HIV status so it was negative.
The patient was HIV negative, tested negative. On December 12th, HREZ intensified. On December 12th, HREZ intensified with LINS and AMIC was given in-house, and patient was sent out on extra dose INH with tapering steroids. Soon after, he developed DILI. HREZ was swapped to LINS, Etham, Moxie, and resharing drugs one by one, while kept him on 4-drug therapy till he tolerated HREZ, withdrawing the extra dose INH. However, the patient kept spiking fevers, did not put up weight. Till at about 2 months into therapy, on 21st of February, he was readmitted with new signs and symptoms. So he developed sudden lower limb weakness and loss of bowel and bladder control in 4 days. On examination, on neurological examination, the GCS was 15 by 15. The neck was stiff. He was oriented in time, place, and person. The upper limb examination was normal. The lower limb showed reduced tones bilaterally with powers down to 2 by 5. The deep tendon reflexes were absent. The right plantar was upgoing. There were reduced sensations up to ZP sternum, which marks to a level of T7. The anal tone was reduced and there was no gibbous on spine examination. So what is the diagnosis? Where is the lesion and what is the lesion?
And it's used appropriately for the patient.
Yes, the addition of lens amikation is going to be a very big part of the talk shortly.
Also, sorry, that T7 can be due to TB.
Yes, that's very true. This patient classically came with a spinal shock stage of transverse myelitis. So transverse myelitis comes up with a rainbow of causes, some of the infections being TB, HIV, VZV, HSV, CMV, and syphilis. Among the autoimmune causes stand ADAM, MS, post-vaccination syndrome. There are some vascular causes for it as well. Alongside, there can be a SOL or neoplasia in the spine, and there are some idiopathic causes of transverse myelitis as well.
Why amikation and lens was.
Yeah, the addition of amic and lens is going to be a big part of the talk shortly. So, considering this, we ordered an MRI spine, the whole spine for the patient. First of all, MRI brain was repeated, and that's how it looks. There are increase in the number and size of the spine, brain tuberculomas as seen. The meningeal enhancement stays where it was 2 months ago. A CT cap was repeated, which still showed miliary lung patterns.
And this is 2 months after starting treatment.
MRI brain is repeated, MRI spine, the whole spine was repeated, and it had some florid findings. Please give me a minute to get on to that. The CSF analysis was repeated once again. The proteins were found raised up to 4.5 grams this time. The WBCs tripled to 1507, with 70% being lymphos. The HSV, PCR 1, 2, and CSF VDRL both came negative, ruling out the possibility of syphilis or HSV transverse myelitis. Interestingly, the gene expert and AFP smear again came positive and came negative, and the AFP culture did not grow either afterwards. So we image this fine. That's how it looks. These are the vertebral bodies over here, and these are the spinous processes. Between them lies the spinal canal where the spinal cord runs. If you can closely see, this is an abnormally enhancing area. This is an abnormal enhancing intradural extramedullary thickening in the anterior posterior sac extending from D5 to D8. The lower pointer points towards the side of maximum cord compression, as you can see. You can also see some tuberculomas, a space-occupying ring enhancing lesions which are compressing the cord. And myelitic changes are very much visible throughout the cord, showing cord compression and edema. Similarly, in this axial view, you can see that the cord is almost effaced by the presence of this enhancing lesion. So in an attempt to get the microbiological evidence of TB, we underwent a BAL for the patient. Grossly, the vocal cords, trachea and endobronchial tree was absolutely normal. Microbiological workup, once again, very interestingly, came up negative. So what next? Where do we stand now? Despite the patient being compliant into second month of first-line DS-ATT, the patient is having clinical failure, radiological worsening, biochemical deterioration with interval development of new CNS signs and symptoms. What next? I asked the audience, what would you do next? The fungal culture was negative, twice negative. That's a good idea. But what about the therapy? What to do now? So let me just show you what we did. Considering these reasons and concerns for neurological sequelae of serious TB, we considered the possibility of drug resistance in mixed bacterial populations and switched him to MDR therapy along with surgical cord decompression. We started him on LTR regimen with bedaquiline, moxilin, cycloserine, and ethionamide. Opinion was taken from trauma center and patient underwent a D8 costal transversectomy with multilimbal heavy laminectomy, decompression, durotomy, drainage, and biopsy of the lesion. Operatively, gelatinous material with milky white collection was seen. And finally, the gene expert was positive, detected with no RR, and smear was +1. Again, though, the AFP culture did not grow. The biopsy of the lesion showed palisading histiocytes surrounding necrosis, which was very much suggestive of tuberculosis. So, speaking about follow-up, power increased to 3/5 bilaterally with drugs alone, later to 5/5 after surgery. Sensations returned. He gained complete control of bowels and partial control of bladder, and now he can walk on his feet without support. A follow-up MRI was advised this month on 18th of July. The previously noted intradural extramedullary thickening has significantly resolved, with the subtle disease, residual disease remaining less than 2 mm only. The pointer indicates towards the site of old cord compression, which is no longer seen. I have two more similar cases to present, but I'll wrap up fast. An 18-year-old girl came with a history of fever, weight loss, and headache for 4 months. Upon workup, her CT showed 3 in blood infiltrates in the lung with bulky spleen, basal engine enhancement. BAL gene expert was negative, so was in CSF. The AFP culture is awaited today. CSF proteins were very high. Considering her disseminated TB with TBM, we started her on HREZ and steroids. While being on therapy, at around 2 months, she was readmitted with new spasticity in the lungs, 3/5 power in the left leg with increased deep tendon reflexes, upgoing plantars bilaterally, clonus, and impaired sensation still L3. There was no sensory level, however. We again imaged her spine, and that's how it looks. And abnormal intradural extramedullary signals are seen within the spinal canal, which are extending from D8 to D12. And there's compression of the underlying cord seen with cord edema. Biopsy is recommended to rule out neoplasia. So we called her a case of paradoxical TB myelitis while on drug therapy and intensified her treatment with levo and referred her to trauma for surgical debridement and a biopsy. Again, very similar, a 16-year-old girl, she came up with fever, weight loss, and dry cough for 4 months. She had multiple train blood infiltrates, trace pericardial effusion, and multiple spinal collections at presentation. From D2 to D7, there were prevertebral, paravertebral, and epidural collections with cord compression and edema seen. Interestingly, her BAL gene expert came out positive with no RR. AFP culture is growing with first-line DST in progress. So we intensified her therapy, HREZ, with levo, lens, and steroids, and referred her to trauma for surgical intervention. This patient at presentation came up with TB myelitis, concomitantly with pulmonary and GI TB at presentation. So I've confided in you the murky truths of the muddy CSF waters we encountered here at Indus Hospital, Karachi. Let's move on to the topic discussion now. Tuberculous myelitis is a rare neurological complication of TB, which involves this infection of the spinal cord by Mycobacterium tuberculosis. As shown, it can either come up as an isolated entity associated concomitantly with TB elsewhere, or paradoxical myelitis in patients already on drug therapy. The WHO global burden ranks Pakistan 5th. The TBM develops in about 1 to 5% of the 10 million annual cases worldwide. Myelitis is so rare that it is not quantified. This table gives a quick look at the important cases and case series of TB myelitis in the last 25 years. Vazi et al. Reviewed the clinical and radiological findings of 10 cases of presumed TB myelitis as described over here in the next slide. So all these patients in this case series were diagnosed on the basis of clinical, radiological, or CSF biochemical findings. None had microbiological evidence positive. Neuroimaging showed preponderance to involve cervicothoracic cord segments. The second series was published in Journal of Neurosciences in 2022 and looked into 52 cases of TB myelitis. 52 cases of myelitis actually, out of them 18 were attributed to TB and found to have raised protein in the CSF. And the most striking radiological feature was LETM. In 77% of the patients, as we saw in our case, LETM stands for longitudinally extensive transverse myelitis when the myelitic changes are spanning in more than 3 spinal segments. Again, getting back, so this fourth study, this was actually a case report by Salari, and he described a report of an Afghani woman who came up quadriplegic. She had CSF proteins of 4.5 grams, and there was C1 to L5 cord myelitis. The CSF gene expert came out positive for MTB. The last case report is reported by Khatida, and this is a case of a young man with transverse myelitis, ranging from C1 to colus medullaris, meaning that it involved the whole of the spine. And the CSF culture grew MTB. This is another very interesting case. It is described in the Journal of Clinical Research Morocco. It shows a 45-year-old woman who progressively developed tetraparesis, sensory disturbances, bladder dysfunction. MRI showed a mass lesion from C3 to C7, and it was diagnosed as astrocytoma. Despite partial resection, patient was not getting better. The histopathological analysis confirmed the diagnosis of TB myelitis, and the blood gene expert was also positive. Patient received high-dose steroids with ADT and physiotherapy, and then she showed slow recovery. I hereby ask the lab experts who are joining us to share their take in the field of blood gene expert.
So the reason why Hira is raising this is because we never do blood gene expert. And this was a case report where blood gene expert was done and it was found to be positive. So perhaps the lab people can tell us why we don't do blood gene expert when it has been reported. Is there anyone from the lab with us? Dr. Zishan, can you shed some light on this?
Can you please repeat?
Okay, I wondered if you could express any experiences you had with a blood gene expert turning up positive, just as we saw in this case reports.
Can you answer? Yeah.
So no answers. We have a question about blood gene expert. Because this has been reported in literature, but we have never heard of it being done in Pakistan.
Hello,
So,
this is Dr. Can I give answer?
Yes, please.
Actually, gene expert has been validated for some body fluids and some sites, but not all the sites. So it is, as far as I know, the expert is not recommended from the blood sample. And if we have to, maybe the reason could be that even the TB culture, intracellular organism culture are generally, it's very difficult to culture those organisms. Though we do culturing of bone marrow, and sometimes special medias are recommended for the blood culture from the for TB, MTB. But as far as I know, gene expert has not been validated by the company itself. But for any sample that is that we want to do as an additional thing, so we have to do a validation study, just like
Yeah, so
you
that's
have
why we
to.
were a little surprised by this case report, because they were reporting it in the blood. So and we have never heard of that.
Yeah, so that we can do it, but we need to find out the literature, because similarly, like pleural fluid is generally it's not validated by the, it's not from the manufacturer recommended body fluid, but we are doing validation study in our lab for the pleural fluid, because we receive lot of requests for the pleural fluid gene expert. So one has to do first the validation study, and then have to start these kind of testing. Without that, we, how can we like say that it's a true thing, or like false thing we have.
Okay, thank you. That makes sense.
Talking of exceptionally high CSF proteins encountered in our case and in the case reports just mentioned, I will briefly talk about Froehlich syndrome. It is a rare condition which is characterized by xanthochromia, which is yellowish discoloration of the CSF, with very high proteins reaching about more than 1 gram, hypercoagulability of CSF, which is caused by blockage in the spinal canal, leading to stagnation of the CSF and raised proteins below the clot. So, finding very high CSF proteins while working on cases of chronic meningitis should always raise concerns for Crohn's and underlying cord blockage. So, in a nutshell, the main diagnostic challenges encountered while working on TB myelitis are diverse case presentation, its radiological mimicking a neoplasia, the hard to get biochemical proof we get, and the anatomically challenging tissue biopsy considering the sensitive nerves running in the cord. Moving to the treatment of CNS TB, I will briefly discuss the pitfalls of the therapy.
Hira, I have a query. Like, why, did you find out anything in the discussion or in the literature why the gene expert from the CSF was negative, even the culture was negative from the
Yes,
CSF,
so this
though it
is
was a active ongoing infection that was not even controlled by the anti-TB drug. Even then, we don't see that your tests were coming positive.
Yes, this is the thing that was interesting, because we sent it repeatedly from the CSF samples. It came out negative, and only from the spinal tissue did we get not only the gene expert positive but also the AFP smear to be positive. And there it was RIF sensitive, although the patient was clearly not responding to the standard HREZ with steroids and worsening on therapy, and even the miliary mottling was not going away. So, and the AFP culture that was subsequently sent from the spinal tissue was negative. But by that time, we had already empirically shifted the patient to MDR regimen. So there was a discrepancy in the findings, and we in the literature, what we were seeing was that in such cases, usually the diagnosis is made on the basis of radiological and clinical findings. The microbiological evidence is usually lacking in most cases.
The main challenge of treating TBM is the suboptimal drug CSF levels, which warrant the need for intensification of therapy, as many were asking in the chat box then. Along with, I would also discuss the role of aspirin as an immune modulator for stroke prevention and disability limitation. So let's see, why is intensification actually needed? This is a schematic overview of the relationship between blood-brain barrier made up by brain endothelial cells and the blood CSF barrier, which is made up by choroid plexus epithelial cells. The antimicrobials for CNS TB must cross these barriers to remain at the site of infection at sufficient concentrations to kill the bacilli. Despite the glycoprotein pumps, which keep out the foreign materials like xenobiotics out, the first-line TB drugs, especially RIF and ITHAM, which undergo these processes, despite this limitation, the national and international guidelines for TBM follow the same model as for PTB with identical dosing. Just prolonging the therapy for 92 months won't work, actually. So let's have an overview of the CSF drug levels of all the first and second line drugs used for TBM management. Amongst the first line drugs, as you can see, INH and Z have good CNS penetrations, but ITHAM and RIF both go in barely 20%. Similarly, amongst the second line DR agents, Moxi, Levo, ethionamide, and CS, along with LINs, have excellent CSF penetration. Bedaquiline shows poor penetration with limited data, while enzalutamide and predominant, we don't have any data to date.
If you can stop here, Hira. Nowadays, we are seeing many MDR TBM as well. So if you could go to the concentration slide. Yeah. So the dilemma is that for bedaquiline and delaminate, there is very limited data on CSF penetration. So those two drugs, even though we are giving them, we don't know how much of them is going to CNS. The issue with cycloserine and fluoroquinolones is that they have a lot of seizure potential. So even if they have good CSF penetration, but they've got a lot of seizure potential. So these patients are prone to have seizures, and then there we get this limitation of how to use them. So we had a discussion with the NTP, and we have proposed that for TBM, because we are seeing a lot of TBM nowadays. I don't know why, but we are seeing a lot of TBM. Instead of giving HREZ, we should have HR ethionamide, because ethionamide has good penetration, and ethionamide is not being used much in the second line regimens because it's not one of the backbone drugs. So it is there, but it is not being used that much. So we proposed that because if we use the standard doses, ethambutol and rifampicin levels are not good in the CNS. So we have, like, for the most serious TB disease, we have less optimal regimen that we are using.
Can I speak a little over here?
Yes, ma'am.
Okay. As I see it, this patient probably had an extremely very high burden of Mycobacterium tuberculosis, not just in the lungs, but it has also spread to the meninges, given tuberculomas, transverse myelitis in the spine. And if you had looked further, would probably also be in his kidneys and lungs, kidneys and liver and most organs. And if you had cultured the blood, this would probably have been positive for MTB. I think this was a case of very high burden TB. And although you used appropriately the standard drugs, but they were not enough to kill all the mycobacteria. They were probably hiding in various parts of the body. To suggest now, this was apparently drug-sensitive TB, but you opted to treat with MDR more out of insecurity, which was justified. But even if it is it is drug sensitive, you cannot now mandate or change the therapy to add more things as a rule. This is an exceptional case, and you've presented 3 exceptional cases where the drugs didn't work. And just as you are commenting that we are seeing a lot of TB meningitis, and we're seeing a lot of very severe TB, people who come in shock, along with TB spread all over. So there is a very high burden, and maybe the TB germ has become more aggressive, or the immune system of our population is decreased now because of malnutrition and maybe HIV or not, I don't know. But be that as it may, I think you'll have to treat these patients as exceptions by adding ethionamide, or bedaquiline or cycloserine, which has a very good penetration into the brain. I don't think we should change our regimen as such, because not all TB meningitis cases are as severe as what you have described over here. I think maybe the high end of dosage of INH and rifampicin may have been all right, but even that may not have worked because the CSF was we had extremely high protein, 4 grams. My goodness, this is all like congealed, solidified CSF, and which is why it was not penetrating. So I think this is my 2-bit in it. I know you had discussed this case at one of our TB CRC meetings, but I think these 3 cases represent very high burden, and you have to tailor your therapy, whether it's a DS or DR, by using the very highest end of dosage. Don't worry about the side effect. Just increase your dose of INH and rifampicin if this is DS, or if it is DR, then of course the regimen also has to be on the high end of calculated drug therapy, the calculation. Thank you.
Thank you, ma'am. And the point we're trying to make is
Can I add another comment on Dr. Naseem's input? Like I rejoined, so I didn't hear much, but I think the another thing we can consider is because of the increased CSF concentration of protein, like protein binding of the drugs might have increased. So the obviously the availability of free drug is responsible for its action. So if generally. Yeah, so that's might be a reason that why the drugs were not acting, because protein binding was so high that free drug was not available. And if we increase that, generally it doesn't happen in the CSF. So maybe that would be another.
That may be one of the reasons, because this was like hair splitting for us, why the patient was not improving and actually deteriorating. So these are some intensified TBM regimens which Hira is going to present.
This table summarizes the clinical studies till 2018, which are investigating the intensified antimicrobial therapy for TBM. The idea is to intensify the therapy either by increasing the dose of RIF or by addition of a CSF labile agent. The biggest of these studies is the one which is highlighted. This is a Vietnamese study published in New England Journal year 2016. It was a phase 3 RCD, which included 19 patients of TBM. The standard of care regimen having normal dose RIF was compared with the arm B, which was intensified with high dose RIF and levofloxacin. During the 9 months of follow-up, the similar 113 patients in intensified TB group and 114 patients in standard of care regimen died, with no difference in mortality as shown in the Cox regression analysis curve. Mortality, however, was seen in subgroup analysis, which was seen for mono-DR cases as highlighted. The good thing was that the study set a ground for bigger study, highlighting that there was no increased toxicity seen, however, even with high dose RIF and levofloxacin. Coming back over here, the second, the first study is an observational cohort study in 203 HIV patients with TBM, which compared standard of care regimen with intensified APT, which included levo, ethionamide, pyrazinamide, and a double dose RIF and INH given for a median of 7 days. The new intensified therapy was associated with an absolute 21.5% reduction in mortality at 12 months, as seen. Here, the mortality, this y-axis shows the survival proportion, while x-axis shows the survival time. At 12 months of time, as you can clearly see, the patients on intensified therapy had a better survival as compared to those on average, the standard of care regimen. And this we're talking about HIV patients with TBM. And similarly, in the rest of them all are phase 2 trials. So phase 2 trials are shorter, smaller trials which are looking at the drug safety, and they set as grounds for bigger phase 3 trials which look into mortality benefit. The second one is published in Lancet. It was a trial conducted in Indonesia in patients with TBM comparing high-dose RIF with moxi intensified therapy for the first 2 weeks. The endpoints were PK analysis of blood and CSF, adverse effects as well, and survival. And it found out that intensified therapy did not result in increased toxicity. And the 6-month mortality was reduced in patients given a high-dose RIF IV, which could not be explained by the HIV status or the disease severity. Another disease in Indonesia in 2017 compared double and triple dose RIF with standard of care, and it showed that tripling of RIF reduced the 6-month mortality and it was found safe. The survival benefit should now be evaluated in a larger phase 3 trial. The third but the last study is a Chinese study conducted in year 2014. It compared the use of adjunctive LINs and found the rapid clinical and biochemical response with intensification of therapy. This is a retrospective cohort study with MRC grade 2-3 TB meningitis who accepted a background of baseline ATT with or without LINs, and as you can clearly see, the GCS recovery score, which is on the y-axis, is 77% in LINs intensified therapy, 80% in LINs intensified therapy, while 70% in the baseline standard of care therapy. But you see, the curve is steeper over here, which shows that intensification of therapy led to a rapid and better clinical cure response. This table summarizes the big trials which were done from 2018 to date. Amongst them, the biggest is Laser TBM. It is a phase 2 open label trial which was published in CID, and it compared the standard of care with high dose RIF and LINs with or without aspirin to establish the safety profile in 52 patients. And here you can see the results. So this is the Kaplan-Meier analysis curve, but it shows the time to adverse effects of special interest. On the y-axis lies the probability of having the adverse effects, and the x-axis shows the time when they develop the effects. So the arm 1 is the standard of care, arm 2 is the standard of care intensified with high dose RIF and LINs without aspirin, and arm 3 is RIF LINs with aspirin. And as you can clearly see, the arm 1 has a clinically statistically significant p-value for adverse effects as compared to arm 3. But here, when compared with 2 three together, this adverse effects are not significant, which shows that addition of high-dose RIF and LINs alone outside of aspirin do not confer higher risk of developing adverse effects, and it establishes a good safety profile of using intensified therapy in patients of TBM. Okay, this table summarizes the ongoing promising phase 3 trials which are ongoing right now. The top one is Harvest trial. It is a randomized controlled phase 3 double-blinded trial which will be complete by this year, and it is being conducted in South Africa, Uganda, and Indonesia. And they are comparing very high dose rate, which is 35 mg per kg, about 3.5 times the one we use in standard of care, which is 10 mg, and they are looking into 6 months survival. Another in-short trial is an open-label multicenteric trial, which has 372, a big number of participants across 6 sites in India. And the arm one is comparing high-dose RIF and moxie with the standard of care arm with and without aspirin, and they are looking at the 1-year survival. The biggest of them all is the intense TBM trial, which can be called a sequel of laser TBM trial. This is a phase 3 randomized controlled trial across Asia, Africa, and Europe, and they are comparing high-dose RIF and LINs with and without aspirin as compared to the standard of care therapy, and they will look into 6-month mortality and morbidity. And this trial is so big and so good that it is thought currently to change the practices very soon once the results are out by 2026. Let's discuss the role of aspirin in TB stroke prevention. A systematic review and meta-analysis for the role of aspirin in TBM was published in Neurology India in 2019, which included these 4 trials. 546 patients were found eligible as shown. In the first 3 studies, low-dose aspirin was used, while in the 4th study, high-dose aspirin was used. This is a forest plot diagram. It shows the comparison of mortality estimates between the aspirin and the control arm. So in the forest, so this line is the line of no. This vertical line is the line of no effect, and this horizontal line shows confidence interval range. And the clustering of this horizontal line towards the left favors the aspirin arm, while on the right favors the control group, which is the standard of care. So as you can see, in these rows shows each of the studies which are included in the meta-analysis. So you can see that while if you compare low-dose aspirin versus control or high-dose aspirin versus control, each time the confidence interval is crossing the line of no effect, which shows that the addition of aspirin confers no benefit in the mortality between the 2 groups. This forest plot compares the occurrence of new infarcts between aspirin and control groups. And just as you can see, the horizontal lines hereby are clustered towards left, and they are favoring the aspirin arm, but for the occurrence of new stroke infarcts. So this concluded that aspirin was found to reduce the risk of new infarctions in patients with TBM with no mortality benefit anyway. This is a very similar article, a review article, which is comparing the same studies published in 2021. It was in Lancet, and it shows exactly the same results. All this data calls for an insight to modify the TBM therapy we have currently. Thank you.
So this was our case. We're very sorry for the initial glitches of connectivity that happened. But are there any questions?
Yes, I would like Dr. Hira to give us the message on these 3 cases. Number 1, the dose of the standard therapy and use of aspirin or not. Just conclude, with clear words in that.
Yes, ma'am. Thank you, Dr. Naseem. And just as we discussed, the idea of this whole presentation was to highlight the fact that the current standard of care WHO proposed therapy for TBM is just identical to the TB elsewhere, whereas CNS is very much protected with multiple blood-brain barriers, CSF brain barriers, which require certain parameters for the drugs to achieve sufficient levels to kill the TB bacilli, which is not achieved by the current therapy. And since CNS TB has devastating neurological sequelae, there's a high time, and we're seeing a lot of them lately. So there's a high time that we need to modify the therapy to make a regimen which includes the CSF penetrating agents so that the patients can be effectively treated, just as there have been attempts lately, but all of them were conducted on small scale, largely phase 2 trials, establishing the safety. So the idea is to comfort the fact that this is high time to intensify the standard HREZ with something which should go into the CNS. Talking about aspirin, the studies are very much befitting the role of aspirin for the new stroke prevention. We have seen a lot of TB stroke patients, very young patients being debilitated for life. And so addition of aspirin is, as the studies show, is going to confer benefit for disability limitation. And we have, on a smaller scale, a few months ago, we've started this as a practice at the department level. And we see the results are yet to be compiled though, but we have made it a standard practice here.
So what are you going to tell colleagues here who treat TB to use, to change their therapy, to increase the dosage?
We just wanted to start a discussion on the topic. And to highlight that there is there are trials ongoing whose results might shape up our practice in future. And the thing is that the idea that we are in practice seeing patients deteriorate on the standard of care despite treatment means that whatever we are doing, and this is not like just isolated 3 cases, these are just 3 cases we picked out. There are quite a lot of cases who do not respond to the standard of care. And the second thing is even intensification with isoniazid, then adding extra isoniazid or rifampicin. For us, it does not work because even on the standard therapy, we see delay quite a lot of liver dysfunction, which again, even if we start off with high dose isoniazid, we have to modify midway after 2 weeks because the liver enzymes are not tolerating and the patient is vomiting more. So this is basically one area where in Pakistan we also need to work as centers. We need to see what is working or what is not. And over here, we are in the initial phases at least, we are using linezolid or fluoroquinolones if there's no seizures to the patients, and also giving them low-dose aspirin to protect them. We don't have any evidence of that. We might like to take it up as a research project. But this is the idea of presenting this case was first to highlight the fact that TB myelitis and TB spine along with TBM we are seeing more cases now. And the other thing is that the standard TB sometimes, even if it is drug sensitive, does not work.
So my question again is unanswered. The next time you see a case of TB meningitis, how are you going to change your how are you going to begin your therapy? Straightforward.
That's an excellent question, Dr. Naseem. I think for me in particular, based on all the excellent data that Dr. Hira has summarized, I would go with HREZ plus probably IV levofloxacin or IV linezolid, depending on whether they have cytopenias or if they're in status epilepticus, along with high-dose steroids and aspirin low dose.
Amir, this is not the first time I've seen a case of TB meningitis. I have experience in the past from my Liaquat National and Indus and so on. And most patients have gotten better. Something has changed. Maybe, as I said earlier, the disease burden has increased. The immune system of patients has decreased. So something has shifted. I'm sure, this was not the run-of-the-mill case way back. This is something we're seeing again and again, TB meningitis, disseminated TB. So something has changed, and I think we will have to, yeah, you're right. We have to study it and maybe intensify our treatment. And I don't know, I don't have valid suggestions, but what I have read in the past and discussed at meetings, at the union meetings, is to use high dose INH and rifampicin. Yes, some may have delay, but some may not. It depends upon, the ALT may go high because of granulomas in the liver, TB hepatitis. So there's a lot to study in this, but I think these were, despite the delay in your presentation, this is an excellent forum for discussing how we should approach TB meningitis in future. Thank you.
Yeah, so I'll just wrap up by saying that this was an excellent effort by Hira, but unfortunately, in the initial stages, we had a lot of connectivity problems, which obviously marred the overall experience of the presentation. So maybe, Dr. Asma, we can consider physical meetings rather than Zoom meetings in future. Because with Zoom, there's always a great unknown of what will happen. So this is just my suggestion to consider physical meetings, especially for people who can do it, like for Shaukat Khanam, and for PIMS, it will always be remote, but at least for the rest of us, we can meet physically so that this doesn't happen.
I agree. I think we should go for physical meetings. It's high time to restart it.
Yes, because initially there was a big struggle. Sometimes the voice was not coming, the screen was not sharing, the slides were not moving, and we, like, the IT person was coming back and forth, and we couldn't do anything. It was just like total paralysis over here.
Yes. So probably with this experience, we can now shift back to the physical one. And I think all Karachi centers should consider this, please. It's high time.
Yes, all for it.
Yes.
If there's no more questions, so I think we will say goodbye from here.
Dr. Samreen, which regimen is he now? Your first case, is he still on the DRTB regimen?
Yes. Because we had evidence that he was not improving on the DSTB regimen. The second thing is that the AFB culture came out negative from the spinal tissue as well. So we don't know if he had isoniazid resistance or some other form of resistance, because if RIF is sensitive, the gene expert was RIF sensitive, but we don't know if isoniazid is also sensitive and pyrazinamide is not sensitive. We don't know. So that's why it was better, because he improved on the MDR regimen even before his spinal surgery. He had started to improve on the regimen, so we just kept him on it.
Okay. And another question is regarding contact tracing. How important is it in the usual practice? Because I've seen a lot of TB centers, they are providing regimen to the patient, but not going for contact tracing.
We try to make an effort over here to do contact tracing. It is extremely important to do contact tracing, because there are so many more people hiding at home who need treatment, and they can be cases or they can have latent TB, so they need to be screened in time. Unfortunately, there is like the issue of in MDR cases, about, there's a discussion on what is the optimal MDR prophylaxis to be given if it's an MDR contact and has evidence of latent TB, or it's basically a household contact of an MDR PTB. So there's again a debatable thing of what should be given to that patient. But for DSTB patients, the answer is pretty clear, and rifampicin with isoniazid, or isoniazid alone, or isoniazid with rifampicin, all three options are available, and I think contact tracing should be done so that we decrease the pool of transmission.
Okay, perfect. And in routine, you go for the MT or IGRA?
No, we go.
We have IGRA available, but we go for question, symptom screening and X-ray. And because as a program, IGRA would be very extensive for us. So programmatically, we use these two things and the history of household contact, because household contact means that exposed, highly exposed. So if their X-ray is clear and they do not have symptoms, they already warrant for prophylaxis. They do not need to have an IGRA done. Programmatically, we're not using IGRA.
Yeah, we have a very robust TB program, and we have found as many as 5 to 10 individuals in the same family, same household who've contracted TB. Some have even multi-drug resistant TB. And not to do contact tracing, even by verbal questioning, verbal screening, I think is a very serious oversight. If you don't ask about the other family members from time to time, not immediately, but even 6 months later, a year later, and if there's any change in symptoms, you test them out. Otherwise, we will never be able to control TB, never. In fact, in Pakistan, the graph is going up, not even leveled off. But we at Indus have such a strong TB program, both DS and DR TB. I think this should be done in many more institutions. We are not the owners of it, but this should be decentralized to more and more places, especially in rural areas, in peri-urban areas. This is the only way we can do anything. Thank you.
Yes, ma'am. Thank you so much. Thank you, Indus team, for a lovely presentation. Okay, so we can wrap up now. Allah Hafiz.
Thank you. Thank you, Allah Hafiz.
मुझे याद आया था The Empire Strikes Back.